for the introduction. So I know I'm the last speaker today, so I'll be very quick, and inshallah, my topic will be also an easy topic. So starting with the usual question about giving the patient hormone replacement therapy after a BSO. For a patient who's known for endometriosis, should we give it or we shouldn't? And what are the concerns of giving HRT? The data in the literature is very conflicting and kind of inconsistent, but most of the literature goes with giving, and the concerns are not the major concerns. However, we need to elaborate more in this topic. Most of the studies, as I said before, it's like a small number recruited. And what we should know that counseling the patient is the key. Always, as I said yesterday, we need to individualize and we need to customize the management with each and every patient. There is no right or wrong answer. There is no yes or no. So the individualization is the key here, and counseling and documentation also. So what are the concerns of giving HRT for a patient who had a history of endometriosis ended by surgical menopause? Is the disease recurrence is number one, and the second concerns are malignant transformation of the endometriotic implants if there is any residual implants. We know that the HRT advantages, this is like the Y study and the others, basically everybody knows this diagram, and we always counsel the patient before we start any HRT about the bone density advantage and minimizing the risk of fractures, the impact on the coronary heart disease, as well as the cognitive function and dysfunction if you don't give it. We know that the average age of menopause is 51, this is worldwide, plus minus. But again, if we're going to give the patient HRT or we're going to recommend it for any patient, ideally, and this is even in oncology, we try not to exceed the average age of menopause, which is 51, knowing that there is a slight risk of increasing risk of breast cancer as well as thromboembolic disease, as we can see it here. So if you're going to give in the future, you may consider the age up to the age of 51, which is the physiological menopause. Okay, so should we give it or we shouldn't give it? Most of the literature or the studies are like graded as low grade or low quality by the grade criteria, which includes, this is the grading system, inconsistency and the bias, etc., to assess the applications. So we're going to go through a few studies here. In one of the studies, this is like randomized controlled trials in Spain, included 172 women. So HRT was given, usually started 4 weeks after the surgery or BSO. All the women were followed for 6 months, and the overall recurrence was very low, was 2.3. And the recurrence was among the arm which received HRT after the surgery. But as we can see here in the last 2 lines, there was a major difference between the patient who had a BSO alone or they had a TAH BSO. That's comparing 1.9 to 22.2. Another study here, it was an observational study that included also a small number, around 100 patients, to give or not to give HRT, and the risk or the likelihood of having, the conclusion of recurrence was 3.7%. And that was again among the users, and all the users, they were on unopposed estrogen. That's another study, again, an observational study with a small number again. All of them had surgical menopause, and then they divided the patients into received or not received HRT. And the number was small though, and they followed the patient. That might be a long follow-up period, but again, there was none like received HRT developed recurrence of endometriosis. So if you're going to give HRT, should you give it immediately after surgery or should you wait? Again, there was no consistent data in the literature, but we believe that the endometriosis is estrogen dependent. So it might be wise to wait for some time before you start the HRT, between the surgery till you start the HRT, which might be justified by waiting. But again, there were like 2 studies comparing immediate versus 6 weeks or after 3 months of surgery versus 6 months, but there was no difference whether you started immediately or not. And again, as I told you, we don't have enough data about when to start it, but again, it might be just a personal preference according to the surgeon who knows what's left there from the endometriotic implants. Lately, that was like a good review that includes 45 articles, Cochrane review, 34 cases as a case reports. That was what summarized like all the data in the literature. And that showed again, some authors, they recommended, they reported the malignant transformation in the HRT users, especially the users who did not use or who used unopposed estrogen. And again, with the low quality evidence, HRT was recommended to start for a patient who's symptomatic after the surgery of endometriosis. And as I said before, you don't start it routinely, but again, if the patient is symptomatic, you may consider putting them on HRT. Whether you use continuous or cyclic, or you use Tibolone. Tibolone is like a compound or a medication where it contains estrogenic, progestinic, or progestin, as well as androgenic content. So it's a mixture of all. So there was one of the randomized control trial concluded that Tibolone might be superior to other components. But again, as I told you, that was the only one. So finally, as a conclusion, that HRT improved the quality of life in a patient who's symptomatic post-menopausal or post-surgical menopause. And also HRT should not decline or should not be refused if in a patient who is known for endometriosis before the surgical menopause. So still, we can give it with caution. So as I said before, the other concerns was the malignant transformation. That was described first in 1925, long time ago, by Samson. It's difficult really to assess or to estimate the odd ratio or the relative risk of having transformation of implants of endometriosis into cancer. But what was interesting is the majority of the cancer transformation of endometriosis was clear cell carcinoma, 40%. It is not endometrioid as the majority we think this is endometriosis, may end up as endometrioid. It is not the case. So clear cell carcinoma is the majority. If the endometriotic implants will become a cancer, it will be mostly clear cell. And it might be one of the most aggressive cancers of the endometrium or in gynecological malignancies. But as I said, it's difficult to assess the risk or the relative risk. But again, a history of endometriosis, if you give it to the patient, some of the studies recommended that you may have to have a closer follow-up with annual checkups and education to the patient, because as I said, the likelihood is there. So we cannot say patient had a hysterectomy BSO, there is no risk or no chance of having cancer. So what was documented also in the studies that the cancer which is originated from the endometriotic implants, it has a favorable prognosis, which is very good and reassuring. So in summary, always remember endometriosis as a symptoms and endometriosis may happen again or occur again in the postmenopausal woman, and always educate the patient to report any endometriosis like symptoms. And especially in a patient who are on HRT, evaluate the risk and benefits of HRT with the patient. And as I said before, always individualize the management. You don't have like a right or a yes or no. I mean, you can just tailor the treatment according to the patient. Always try to involve the patient in the decision. Ask the patient why she needs it, because sometimes patients just ask for HRT because their friends, they do have HRT or they're using HRT. So always ask the patient why, and ask the patient what is the most bothering symptoms for her, and then if you think she may benefit. But again, if you're going to prescribe it, as I said, try to stick to 51, which is the average age of menopause. And always remember, there is a small risk of malignant transformation. As I said, it's a small risk, so we may need to keep it in mind, but it shouldn't be a reason to stop or not to give HRT to the patient with history of endometriosis. It is also advisable to have a careful workup for any patient with symptoms, and if like the workup includes imaging, etc. And if there is any lesion, a tissue diagnosis is a must. Thank you very much.